Hi, today we're going to go over some board questions that have to do with children with developmental disabilities. So hopefully some of the things we talk about will help when you take that big exam. Question 1 is a 14-year-old girl with Down syndrome, and she presents to the office for her third visit over the past month. She is wheelchair bound, and she frequently thrashes her legs against the chair when she's frustrated. She has been unable to participate fully in school. She frequently falls asleep during activities, and she is difficult to awaken after her morning bus ride. She seems to be in pain, and she's tender with movement of her pelvis during her incontinence pad changes. And her evaluation includes the following lab tests, and I'll read those to you. Her white blood cell count is 500. Her red blood cell count is 2.4. She's a hemoglobin of 8.9, hematocrit of 25, platelets of 90,000. Her PMNs, her polymorphs are 10%, the lymphs are 70%, with 90% blasts. Monocytes are 1%, basos are 0, and eos are 0. And our choices are, which of the following is the most likely diagnosis? And to answer this, some clues are that acute lymphoblastic leukemia, ALL, is one of the most common in Down syndrome, and ALL is the most common pediatric form of cancer in kids under the age of 15 years old, and with an incidence of 4 in 100,000. Some of the signs and symptoms of ALL are malaise, anorexia, intermittent fever, pallor, petechiae, and purpura. One of the problems in assessing kids with developmental delays that are nonverbal, that are wheelchair bound, and that thrash with frustration is that they frequently have lower extremity bruising just due to the behavioral outbursts. Other things to think about in this scenario is WBCs greater than 100,000 with myoblasts on blood and bone. We usually see that with AML, not ALL. With Hodgkin's, we see painless cervical lymphadenopathy. Their CRP and their SED rates are usually elevated, but their CBC with the white blood cell count is usually normal. And for the last choice, for mono, we usually see an increase in the atypical monos, obviously in the CBC, but we also see lymphadenopathy. We may see fatigue and some of the other general malaise type symptoms, but certainly not with the bruising like that. So again, for this question, ALL would be the best answer. So question 2. Tony is a 12-year-old child that's significantly developmentally delayed after a severe bout of bacterial meningitis. What is the most likely etiologic agent, which is the most common for the pediatric population in the United States? The answer for this is Streptococcus. And even despite the increase in vaccinations and the aggressive vaccination campaigns, it is the number one cause of bacterial meningitis. The other big culprit, H-flu has actually gone down with vaccinations. So again, for bacterial, we're still looking at Streptococcus. As far as notes on the other one, Neisseria meningitis is a lot less common, and we see that more in neonates, 2,400 to 3,000 cases a year. And the same with Listeria. Listeria is actually not as common, and it's fecal contamination. That's also seen more so with neonates rather than an older child. Although this question, if you notice, does not say how old the child was when the bout of meningitis occurred. Question 3. A routine physical examination of a 14-year-old girl demonstrates dark, coarse, curly pubic hair spread sparsely over the pubis symphysis, as well as elevation of the breast and areola without separation of their contours. According to Tanner's stages of sexual maturation, at which stage would you assess her sexual maturity? Now, when we talk about Tanner staging, and with some of the developmental disabilities, you may actually see some early development of the secondary sexual characteristics. But as far as Tanner staging, we'll go through the routine Tanner staging that we should follow. And frequent question is when the girls start developing their secondary sexual characteristics, frequent question will be, well, when will we expect them to start their menses? And it's usually 18 to 24 months after the development of some of the other sexual characteristics, and usually about a year, within a year range, either before or after the same age they were when their mother started. So there is some genetic tendencies in that. So when we talk about breast development, obviously Tanner stage 1 is none. Tanner stage 2 is a small raised breast bud. And remember, the palpation of the breast bud, frequently it's not directly under the nipple. It may be to one side. And that is a frequent pediatric visit with a breast lump. The parent may be worried about cancer. In actuality, it's just a breast bud that's a little off center. And we see that, as early as 7, but frequently by about 9 or 10 years old. So you can imagine how mortified these girls are to be dragged in for their primary care provider to palpate the breast bud and tell everybody it's normal. So stage 3 is further elevation of the breast bud. Stage 4 is the areola and papilla form a secondary mound. Okay, so again, those are elevated off. And then stage 5, Tanner stage 5, which is adult female, and that's when we get the breast contour of the rounding and the elevation that's appreciable from the side view also. Tanner staging on pubic hair, okay? And again, sometimes what can happen is the breast development and the pubic hair may not be at the same stage. They're usually within one stage of each other. But sometimes you may have to, Tanner 2, 3, with a slash between the 2 and 3. And that means that the first one is obviously, it's the breast development. After the slash, the secondary Tanner numbering is the pubic hair development. But to review pubic hair, Tanner stage 1 is none. Tanner stage 2 is sparse and fine and downy. There's usually not much color to that. Stage 3 is located just at the mons pubis, and that is dark and it is curly. Stage 4 is coarser hair, and both the labia and the mons pubis are then covered with the hair distribution. And Tanner stage 5 for pubic hair is medial, and it goes down the thighs. So for the answer for this, she would be at Tanner stage 3. Your patient's been diagnosed with chromosome 18p minus syndrome. The condition has both growth delays and developmental delays. The mother wants to know what would be the expected weight gain for her baby, who weighs 8 pounds at birth, if the child was on target for growth. So this question is actually asking your knowledge of normal growth and expectations to tell the mom for comparison. Things that we remember is a lot of babies can lose a little weight at birth, sometimes up to 10%. We want to see birth weight gained by 2 weeks. We want to see their birth weight doubled by 4 months. So between birth and 4 months is a fantastic growth period. And they should triple their birth weight by 1 year of age. So the answer for this is a child that's developing typically would be 8 pounds at 2 weeks, 16 pounds at 4 months, and 24 pounds at 12 months. Your 3-year-old patient's autistic and has a gross motor delay. He falls down consistently. You receive a report that he was seen in the ED last night. The parents give a history of him falling at school 3 days ago. Which of the following colors would you expect the bruises to be if this is as it occurred, if is what was stated occurred? And it's a special problem ruling out intentional versus unintentional injury in children with developmental delays, especially autism, where they can be very, very active and they are not verbally communicative frequently, and they're usually not very good historians, and especially at the age of 3, it's problematic. So what this question's getting at is the color changes in the stages for the bruising and how you would evaluate that. On the first day, we usually see swelling. There might be a red mark, or there may be actually no discoloration at all. Days 1 through 5, it's usually purple. Days 5 through 7, it's usually green. 7 through 10, days after the injury, it turns yellow, and 10 to 14, it's usually brownish, and then it's usually gone. So with this, it's 3 days, so it's between the 1 and 5 day mark. So we would expect to see purple bruises for a story that would be consistent with that. Huntington's disease has which of the following types of genetic patterns of inheritance? Huntington's disease follows fairly true Mendelian genetics, and it is an autosomal dominant disorder. A 6-month-old infant with inborn error of metabolism presents to the emergency department with a 2-day history of vomiting and diarrhea. Upon physical exam, she appears to be intermittently irritable and restless with minimal tearing when crying and dry mucous membranes, and her cap refill is 2 to 3 seconds. Her urine sodium is less than 20 milliequivalents, and she's mildly oliguric. On the basis of these clinical manifestations, what would you assess her level of dehydration? So again, a very, very common board question, because it is asking for you to assess the levels of dehydration. So the answer for this one, and I think we got cut off at the last one there, but this child is mildly dehydrated with intermittent irritability and restlessness. They have decreased tears and usually a capillary refill of about 2 seconds. For her to be moderate, so 6 to 10%, we would have decreased skin turgor. She would have dry mucous membranes and little tear formation then. For moderate dehydration. For severe dehydration, this is when we see a drop in the blood pressure with parched mucous membranes, mottling of color, and no urine output. So again, one of the big things to stress in here is that unlike adults, we don't see the decrease in blood pressure for the kids, the hypotension, until they're already severely dehydrated, because they compensate much differently. They compensate by their heart rate and not their blood pressure. So something that's really important to remember, not only for care, but for answering the boards too. A 2-month-old well child checkup, and the female is noted to have the following physical findings: widely open anterior and posterior fontanelles, a large protruding tongue, coarse facial features, low set hairline, and an umbilical hernia. In the newborn period, there was a prolongation of physiologic icterus. The results of the newborn screening test are abnormal. Which is the most likely diagnosis? For this child, congenital hypothyroidism is the most likely diagnosis. She was probably screened for that at birth. We would also expect to find a increased TSH and a decreased T4. She's probably of a low or decreased muscle tone. Now, some other things to remember too: congenital adrenal hyperplasia, only 14 out of 50 states currently screen for that. We usually see more abnormalities of the genitalia with that one. And Krieger-Najjar is severe elevation in hyperbilirubinemia. Symptoms consistent with galactosemia, the last one, is cataracts, hepatomegaly, and they have prolonged jaundice, and that's a non-obstructive type of jaundice with the galactosemia. That one is screened for very commonly by most of the states, and we usually correct that with formula. And some of the characteristics of that actually can be reversed with the formula. Frequently, we'll see an improvement in the cataract formation. Question 9: which of the following newborn reflexes should still be present at the 9-month checkup? So this one is wanting to know if you know when the appearance and the disappearance of the primitive reflexes. And this is a very, very common board question. So you recognize not only the normals, but what are the abnormals when you do see them? The answer to this is the parachute reflex. The parachute reflex we usually see at about 6 to 7 months, and that persists through the rest of life. The Gallant and Landau, the Gallant and Rooting usually disappear by 2 months of age, and the Landau is disappeared by 6. So those other three should be gone by the 9-month checkup, but we should be able to see the parachute reflex. And question 10, which of the following is the most common lethal genetic disorders in the United States? And this one is a little bit tricky. Okay. The answer to this one is cystic fibrosis, because it's one of the most common at 1 to every 3 to 4,000 live births in the U.S. Okay, and remember, these rates can differ with country to country, so I'm giving you just the U.S. ones. It is common and it is lethal. Trisomy 13 is lethal, but it's not as common. Those children generally die before the age of 2 years, but it's actually pretty rare. We're usually talking about 1 in every 10 to 15,000 kids. So trisomy 21 is common. It's 1 in 500. So it's not rare. It does meet the common, but it's not lethal, or frequently not lethal, unless the kids have some of the significant cardiac defects, usually ventricular defects that occur with it. So that could lead to the lethality of it, but it's frequently not lethal. And the neurofibromatosis also, it is a relatively common genetic disorder, but it's not usually lethal. Some of the physical characteristics are minor, but it wouldn't be considered lethal. So this one, again, you want to focus on the fact that if there's 2 descriptives in the question, that the answer that you pick should match both. So hope these are helpful to you, and we'll certainly do some other sets to get in practice for taking those boards.